There are resources for that.
Yeah, there are resources.
There is.
So do we need to start over?
Yeah, I got it ready to go.
All right.
They should be able to hear us now.
Yeah, let's do it.
All right. Hello and welcome to the season finale of Season 1 of the Medic Assessment. We apologize. We were hitting some technical difficulties there real quick, but we are back. My name is Greg. I am back with you. Super excited to be here. I'm one of the co-hosts. My other co-host is...
And I'm Alex, your other host. Very excited to be here with you for the season finale and can't wait to get started. How are you, Greg?
I'm good. You know what the best part of this is?
What's
that
that?
I can see the live feed on the screen in front of me, and I can just watch you from behind the screen. So I'm just looking at everything that you're doing at this point. So you can't hide from me.
Well, we've got some really, really excellent guests today.
Yeah.
So we promised you guys that we'd get some medical directors back on, and we delivered. So to my left here today is...
Mark Contrato. I'm a medical director for a large ambulance service that services west side of the Twin Cities and a large part of Minnesota.
Welcome back, Mark.
Yeah, we're excited to have you back on. He's wearing a Hawaiian shirt that says Honolulu Fire on it, and that's all I want to say about it.
The official Hawaiian shirt of the Honolulu Fire Department.
Huh.
For the record, I wasn't making fun of your shirt, but I think Alex was.
Yeah, that's all I want to say about it.
Yeah, but he does that all the time. It doesn't matter.
All right. And
Welcome back to the show. We appreciate you being here.
And we're also joined by...
I'm Carrie Haley. I am a medical director over on the east side of the Twin Cities for a couple different services and also some of western Wisconsin.
Welcome to the show.
Thanks.
It's good to have you. Yeah. We are super excited to have both of you here. You both work in medicine. Obviously, you're both physicians, and you both work as medical directors. So we have a ton of questions that we're going to be asking about EMS. But before we begin, since our audience kind of already knows Mark, Carrie, can you tell us about yourself, where you come from, and what your work history is?
So I was raised in Minnesota and then went and did my medical training out in Wisconsin, Milwaukee.
Okay.
Did med school and my emergency medicine residency out there. Came back here, so I'm fellowship trained in EMS and decided to stay out here and do my thing out working both clinically and in the emergency department and EMS.
Awesome. So why EMS?
For me, it would have to do more with figuring out a way to service more people. So it's great to see people in the emergency department, but I thought it would be really neat to be able to provide medical care on a larger scale, and I thought EMS was a really neat way to do that.
Sure. Yeah. Awesome. Did you work as a EMT or a paramedic or anything like that?
I got my EMT during college and did some volunteer stuff, actually, at the Excel Center.
Oh, really? Nice.
Yeah.
Oh, yeah.
Yeah, and with the Red Cross when they
Yeah.
were doing it, and but then didn't really do too much after that. Just kind of went straight to med school. And
Sure. Yeah. So did you do your fellowship and then do you work as a medical director? Are you an assistant medical director, or how does that work?
So we have a four of us who kind of work together.
Sure.
I am technically named medical directors for a couple smaller services out in Wisconsin right now.
Okay.
So taking a little bit more primary responsibility for them, but it's
Yeah,
kind of
yeah,
neat to work in a little group of people to do different,
Awesome.
shoot ideas off of.
Awesome. Cool. Well, Alex.
Yes,
Alex
sir.
is just sitting there looking at his phone the whole time.
Alex is making sure that everything's working smoothly.
Alex, are you going to do some rapid fire questions for Carrie, for Dr. Haley?
Yeah, absolutely. So, Dr. Haley, what's your favorite Star Wars movie?
I can't say one of the first three.
Okay, but
Original three.
saying one of the original three is as good of an answer as saying any of the original
This is true.
three.
Yes, this is true.
Okay, who's your favorite superhero?
Wonder Woman.
Oh, great answer. Really great answer.
It's my daughter's favorite, too.
Yeah, all right.
Pretty badass.
Favorite album recently?
That one's hard. I don't
know anybody that
know.
answered that, yeah.
That's a really hard question. I don't know. I can't say.
That's okay. And the last one is suddenly going to escape my mind. The butterfly just hit. Netflix.
Oh.
Are you watching anything on Netflix right now?
I am, yes. And it is The Incredible Kimmy Schmidt.
Oh, that is
yeah,
great.
Yeah, I've seen that, yeah.
Yeah, that's a great show.
My wife watches that show.
Titus is my spirit animal.
Yes.
Yeah.
It's hilarious.
All right.
So for those of you who are watching across the world, again, this is kind of our cap of season 1. It's just been an incredible season from the moment that we started it. When Alex and I first started the show, we started in this rinky-dink little closet of a room, which Dr. C was in before when he previously recorded, with very minimal equipment. We didn't have a whole lot going, and then it just kind of exploded and it blew up. And now we're close to 8,000 people that follow us on Facebook, and even more than that, 2-3 times as many people as that actually download the podcast. So we
respectable 25 Twitter followers, guys.
I haven't thought about Twitter in a while. I haven't checked it. I usually leave that to you, but
check it.
It's just kind of blown up. It's been awesome, and we're really thankful for all the people that kind of follow us. And in regards to that, we have a whole group of paramedics. So if you were watching the podcast or the live feed before we started the second one, we were having some technical difficulties. And we have 10 paramedics and their spouses in the other room who are going to contribute for this show. And I expect both Dr. C and Dr. Haley just to drill them as soon as they get into this seat. So if you can see the little empty seat, which is right next to Dr. Haley, that is where our last guest is going to go. And we're going to pull him in on some of our topics here as we get going. But first and foremost, Alex.
Yes, sir.
What'd you think of Solo?
I thought it was tremendous.
Who'd you see it with?
I saw it with you and Chad, who was another one of our season 1 guests, and Chad's spouse, significant other.
I think you could call her a wife.
Yeah, and
yeah. She wouldn't. Yeah, she wouldn't object to that.
And then
Chad
Lauren
might.
came with us,
Yeah.
so I had a really great time. I'd put it somewhere in my top 3. Unfortunately, I go Rogue One, Empire, Force Awakens tied for 2. And then I think I'd put that pretty comfortably at 3, unless Jedi was 3.
So who's Lauren?
Lauren's my girlfriend. She's in the other room. Greg always wants me to talk about her, and that's the end of it.
I tried to convince Lauren to come into the room with us, and she said that I think that's a season 2 thing. So she'll be on season 2, which is fine.
That sounds reasonable.
Unless we convince her somehow to get in this
That's
chair. But yeah.
reasonable.
All right.
So I'm going to start off with some questions to you, Dr. Haley, if that's okay.
Sure.
And you're okay with some tough questions? Well, I think they're tough. They're probably not tough.
They're probably tough for me as well.
Tell me about the oxygen hemoglobin dissociation.
We're not talking about that because I hate that.
It's a logarithmic curve.
Oh gosh. So tell me, and we'll start off relatively simple. Have you ever felt nervous or scared as a practicing physician?
Yes.
When?
Probably almost every shift.
Okay.
And
That's a good answer.
really scared, like my first year out for sure.
That goes away. It does. It goes
does.
away. Trust me.
I'm still pretty new out. I graduated back in 2015 from residency, so I'm a pretty new doc out on my independent practice on my own. But still get nervous every shift a little bit.
I think that's really refreshing to hear, and I think the layperson would think that docs are immovable and more they're just these never nervous, whatever it might be, and I think that makes you more like a human, which makes you a better clinician and better at your assessment, all those kind of things. But Dr. C, can you talk about how that nervousness affects you early on in your career as a physician,
Or even now?
Even now, good question. The consideration is when you're first starting out, you've had these years of training. You've had med school, you've had residency. I was kind of a slow learner, so I did 2 residencies. I did internal medicine, then emergency medicine, because I was kind of a slow learner. But it helped. And the consideration was you learn better how to process. You never lose that slight degree, I wouldn't say of fear, but of apprehension. It's always there. If you lose that, then I think you're actually in trouble, because now you have gotten to the point where you are complacent. And if you're complacent, you miss things.
Sure.
So I like to say I always listen to the little voice in the back of my head when I'm doing something and I'm working up a patient, and I have the little voice in the back of my head says, "Hey, what about this?"
Have they decreased your dose of risperidone recently?
No.
Okay.
Actually, no, they have not. I said it was one voice, not many.
That's why I'm funny.
The one voice.
Yeah, but it is. You learn. As Dr. Haley said, yeah, you get apprehensive of things. one of the things, I have 50 plus partners in my practice.
Sure.
And one of the things almost uniformly every one of them has said is they go home and they think about patients that, did I make the right diagnosis? Did I do the right thing? The thing in emergency medicine as opposed to, say, family practice or pediatrics, and emergency medicine is truly primary care.
It is.
It is primary care. It's just primary care on steroids and lots of them. Okay?
Yeah.
It is. We have a much shortened time course to evaluate things. And the other consideration is I like to think about you only have one chance to get it right.
Yep.
So you don't have that chance to reevaluate the patient and say, oh, let's have you come back next week and see how you're doing. You don't have that chance.
Mm-hmm.
And you have one chance to treat this condition, one chance to make the right diagnosis. And that really defines it for me.
Do you guys think that the two kind of rises that we're seeing in healthcare, which is the era of customer service, which has been very big for all of our facilities,
Yeah.
and also the performance-based payment system that the government's implemented, has that decreased that bedside time for you, or does it kind of tear you guys apart in that you want to do good customer service and take good care of your patients, but also there's this pressure to perform and see everybody? Has that changed for you guys?
I'd say it probably depends on where you're practicing. I'm practicing in some smaller hospitals, so a busy shift for me may not be the same as at a larger hospital that is seeing hundreds of people, 100 plus people a day. So I feel like I'm not necessarily driven as much by the patient satisfaction, because I can usually take the time
Sure.
to
Totally.
talk with people
Yeah.
fairly well. But it is sometimes the more of the performance thing, because that kind of goes back to documentation. A lot of it is if you didn't document it, it didn't happen. So I find that is the more problematic portion, where obviously this is what I was thinking, but I didn't necessarily write it down, so it didn't actually happen.
Yeah.
I'm familiar with the documentation thing. I've got a pretty reasonable handle on that.
One of the things that has changed hugely is the emphasis on documentation. When I first started at the place I currently practice, we had paper charts.
Mm-hmm.
And no matter how sick the patient was or how benign the patient was, everything went on one sheet of paper. That was it. Okay?
Wax
That was
tablet.
Right, really small.
Including the labs you were ordering, everything else, it went on one sheet of paper. Which was challenging at times, okay? But now the documentation, it's not only what you were thinking, it's why you didn't think of other stuff.
Sure.
Why you didn't do this and when you did that.
Yeah.
To me, and Carrie, I'd be interested in your thoughts, documentation takes up so much of my time.
Yeah.
And to me, that's where I think patients lose. Because we are documenters, and when you look at all the when you look at the documentation systems that are in the hospitals now, what they're not giving better documentation, they're not giving better patient care, they're capturing more revenue. That's what they are. They're revenue capturing devices.
Yeah.
Yeah.
Before we get, I don't mean to cut you off, I apologize. Before we get into the next question, I just wanted to emphasize that. What?
No, I'm just listening.
Slowly, all I see is this small little thing between my monitor, and I just see Alex's face appear. Before we get into our next question for Dr. Haley, if you have a comment or a question that you want to put in the comment section for us to answer, Dr. C, Dr. Haley, myself, Alex, and one of our guests would be happy to answer that. So if you do want to do that, I think this is my scotch arriving. Oh, welcome. Welcome. Have a seat.
Well, then I should have brought my own.
Well, you can go get it and then come back. Yeah, we'll bring you in here.
But Greg,
Jason,
I just want to add one thing about the documentation.
Yeah.
Because that has become so important not only for hospital professionals but for pre-hospital professionals as well. And that goes back to that pay for performance. That's where that goes back, and that's what's really kind of driving this whole documentation.
Sure.
And
So
Go ahead.
I was going to say, so that kind of puts me in my, and maybe we won't use documentation for this, but so tell me, because I know you're going to say documentation for this, the answer to this question. So tell me that and then something else. So, and I guess, Carrie, you can start.
Sure.
So tell me, where do paramedics come up short in their understanding of medicine and how they work in the field, and where can we improve? Brutally honest.
All right, so we'll say documentation just to get it over with.
Truth.
I think one thing that I've always, and it struggled with, like in the emergency department as well, is the people who you think are ill, but they don't really want to go with what you want to do. And I think that sometimes potentially pre-hospital there's an easy kind of give way of saying, like, okay, fine, you don't want to go to the hospital, we won't take you to the hospital, sort of thing. And thinking about escalating that, having a doc involved with that decision-making process, because sometimes there are people who they're not technically, they're not intoxicated, but they are definitely acutely ill, and maybe there are more finesse ways to convince them to get the attention that they need.
Sure. Okay.
We watch no loads pretty closely, and
Jason,
I think it's fairly alarming the rate at which no loads can occur, depending on system to system. The last national number I saw was close to 15%. I think not taking 1 in 5 patients to the hospital is awfully high. Nearly 1 in 5 patients to the hospital.
And there's articles out there saying, no loads have a pretty decent high morbidity mortality.
Yeah. And, the consideration when you look at no loads is part of it is how the patient perceives the person who comes to see them. And we talk about customer service, but as well as I do that if you go whether you're going into a fast food place to get something to eat, or you're going to the grocery store, or you're going into the emergency department to be seen, those first few minutes of that interaction are key. You have to take a step back. You have to say, what made this person want to call an ambulance?
Sure.
Okay. Now, some people just call the ambulance because, hey, that's the only way they're going to get to the hospital. But you have to understand that why did this person call the ambulance? You have to take that next step. Is why did this patient feel that bad that they wanted to go to the hospital? Mm-hmm. And that's kind of one of the questions I go to people when they come in, and I'll say, well, you've been having this pain for a while. What brought you in today? Mm-hmm. What's so much different? Or what concerns you? And I think that's the level and you have to kind of reach them on.
Sure. Welcome to the show, Jason.
Hi.
How's it going?
Good.
Jason, do you know our phenomenal doctors that are here?
I've met I think I've met you before.
Yes, you have.
How many years ago?
We won't say.
And Carrie, obviously.
Yes, and I know Carrie.
Yes.
So Jason was on our show previously as one of our guests to talk about 30 years in EMS, how to avoid burnout, how to avoid some of those things that can kind of catch you up as a paramedic, and then how to be successful, really, over the course of 30 years. So, Jason, first off, thank you for coming back to the show and drinking my booze. Thank you for going getting my booze. I appreciate it.
Thanks for the drink.
Absolutely, yes. You drink as much as you want. But your show was also very, very popular. And I think the topics that you talked about resonated with a lot of paramedics because Dr. C and Dr. Haley, there is... or maybe we should say there used to be a stigma in EMS of where, like, you don't talk about how it was a struggle and the stress and that kind of stuff that comes with the job. And I think that's slowly changing because of individuals like yourself, Jason, who have evolved over the course of 30 years. Would you agree?
I've evolved. Wow.
Your prehensile tail.
Yes.
But yeah. So
you're right. It was that way when I started. You don't talk about things. You man up, suck it up. This is the way it is.
Right.
If you can't do this, you don't belong in the job. And now it's changed.
So, Jason,
Or
I'm
is
going
changing.
to ask you the next question,
Uh-oh.
or the same question, actually. So, in your opinion, where do paramedics come up short in their understanding of medicine, and where can we improve?
Documentation. I was doing peer reviews today. Documentation.
We can stick with that. I mean, that's a pretty. You could just say that across.
Yeah.
Can I answer this question?
Sure. You are a co-host. You've been staring at your phone for about 20 minutes.
You
but
told me
are
to
a
watch the
co-host.
comments.
They're making comments in
They're
there.
making
I'm aware. So, I work in a QA office, so documentation is probably the key answer. But I think the biggest shortcoming that I've seen over my career is that we can't just always do the vomit for the patient. You know, every patient gets vitals, oxygen, monitor, IV, and transport. You don't need to just vomit for everybody.
Mm-hmm.
We need to start making decisions that make sense for the patient. There was a study out of Australia a couple years ago that 1 in 4 pre-hospital IVs using chlorhexidine still developed a staph infection within 2 weeks of the venipuncture. And we start a lot of IVs because, quote, they'll probably do that at the hospital. They also do CT scans at the hospital, and we're not going to start doing that in our ambulances anytime soon, at least not up here.
Why not?
Because it doesn't do anything. And if you would like to drive the ambulance with the nuclear medicine machine in the rear of it when it crashes, be my guest.
Probably
But
not.
that's how you become the Incredible Hulk.
Probably not, no.
So that's where I'm at with it. Is, you know, you look at these charts like, oh, they did a 12 lead. Why? Like, I don't mind, but think about why you're doing the procedure. Don't just do it, because it does do something to the patient.
So next question, and this, any one of our 3 guests who are sitting with us right now can answer this question, and then we're going to cycle you out for somebody else. If that's okay. Not that you're uncomfortable by any means. You are super comfortable. So the question is, has the career of medicine ever caused strain in your personal life or personal relationships?
I do have an ex-wife.
Okay. Anybody else that would like to answer?
Totally.
You don't have to answer.
It's interesting because Dr. Healing and I are kind of in different generations for this, which is very interesting. I'm willing to bet that Dr. Haley was probably born right at about the time I finished medical school. I won't ask. That was in 1986, so that's when I finished medical school.
I was 1 year old.
I was 1.
Oh,
Okay.
For what it's worth, Dr. Contrado, my parents had just met.
I know. We discussed this the other day, yes.
And that's when I started in my career.
Yes. And
we're aging both of you.
I know.
It has changed. It truly has changed incredibly. One of the things, just as you mentioned, you manned up, or womaned up,
Right.
You didn't let things show.
Mm-hmm.
I was at the trailing edge of that theme of medicine. The doctor always knew best.
Yep.
And you didn't question the doctor. Okay? They knew what was right. I was at that trailing edge where the doctor did something. They didn't need to explain it to you.
Yeah.
They just did it.
Right.
Okay? And they just say, trust me, it's for the best. Okay? And that has changed tremendously and much for the better.
Sure.
As far as I'm concerned. Now, as causing stress in a relationship, absolutely. When I first started here in the Twin Cities, my wife and I had been married about 3 years. We didn't have any children. Within about 5 to 6 years after that, we had 2 sons, and I had opted to start working weekend nights for the most part. And after doing this about 3 years, my wife said, "You're done. Okay, you're done because I need you here. I can't have you just doing this."
And she's the boss.
And not she's the boss. It's that I completely understood why.
Yeah.
And I said, "Okay, no problem. We can change this."
Yeah.
Okay. And that's part of that is it did cause stress and that did cause a stress and a strain. But you have to be, you have to adapt.
Yeah.
Dr. Haley, how about you?
Yeah, I mean, I think my husband and I were married right before I started medical school, and then we had our first kid at the end of my second year of med school, and then we had our third during my residency.
Oh my goodness.
Or my second, and now we do have my third. So we have 3 kids, so it's definitely very stressful, just that in general. But I think my husband has made a lot of sacrifices in order to keep the family going, because he requires a lot of weekend and evening and night times along
Sure.
with the kids.
Does he work in medicine?
Nope, he works in computers.
Awesome.
Yes. So, luckily he has the 9 to 5 normal job, but
Yeah.
technically we're both 2 full-time working
Yeah.
parents, and one of them has just crazy, ridiculous schedules.
Right.
So it definitely causes a lot of stresses and strains, but I think for the most part we're working through it, and I think there's a good, as you mentioned, kind of good movement in medicine in general, and just to have that work-life balance a lot more, and just being a part of that is kind of cool.
Yeah,
And
absolutely.
my wife, when we finished, she was ready to give up her career when we moved here. She had been in neonatal critical care transport, so she's probably logged far more hours in helicopters than I ever will.
Sure.
And
Thank goodness.
she was ready to. She said, "I'm done." She said, "I've done that. I'm ready to. I'm done. I'm ready to go somewhere else."
You're getting a medical direction call right
I
now.
am. I can tell.
So,
Hang on, I have a follow-up.
The bat signal just showed me.
yeah.
I take back all the bad things I said about Batman after the last 2 series. Dr. Haley, you have younger children?
Yes, they are 8, 5, and 1.
Okay. Do you ever watch Dr. McStuffins and go, not accurate?
Yes.
Yeah.
Yes.
Oh, I have a question for you, actually.
Oh, yeah.
So you have 3 kids, and
Yes.
you have children too, Dr. C, right?
Well, they are now considered young adults.
So did you, when they were younger, Mark and Carrie, currently, do you take your kids to a pediatrician, or do you take care of your children yourself?
I do take my children to the pediatrician.
Why?
Why?
Well, I'm just curious.
Oh, yeah. Oh, for me, I feel like, I don't know, especially with being a mom, I feel like I get a lot. The mom takes over the doctor
Yeah.
brain, and sometimes the doctor-mom brain doesn't mesh very well. So
Yeah.
especially in emergency medicine, where I'm like, worst case scenario, oh my gosh, they're dying.
Right.
Definitely
it's-
tracheitis.
So it's really good just to go to a pediatrician who's just like, okay, we're good.
Yeah.
Why don't we do this? And not have to come up with the plan yourself, because you do that at work all the time.
Right. I think that's really interesting. I'm curious as to what docs do.
I
you, Dr. C.
completely agree with Carrie.
Yeah.
This was, I completely agree with this. You need that detachment. You do, because you will either undercall something or really overcall something. My wife, I remember almost 20 years, about 15 years ago, we were coming back from a family vacation. She goes, "Oh, my throat really hurts." I look in her throat and I go, "Well, you got a peritonsillar abscess." "No, I don't." "Well, yeah, it really looks like it." I said, "Why don't you go see my friend the ENT?" And she comes back the next day and she goes, "So, what did she say?" "Well, I have a peritonsillar abscess."
And
I said, "Okay."
and working for Dr. Contorado, he does the same thing too as an employer. God, my leg hurts. It's like, it's a DVT. Go to the doctor.
So before we move on, I want to give it back to Jason real quick, and then we're going to excuse you from the chair. But we appreciate you being here and appreciate you giving us our quick insight and being supportive of the podcast. Jason, do you want to be back on season 2?
Sure. Yes.
Awesome.
To celebrate 31 years.
31 years.
And I'll be here for
31
32.
years. 32.
It'll be 32. Yes.
So, Jason, if you would, do you want to go at random? Tell one of the other guests that they are required to sit right there in that chair, and you can pick whoever it is.
Ooh, okay.
Whoever it is.
Can I have the next question?
You certainly can, yeah.
Jason, may I
Yes.
make a request? When the next guest comes in, can they bring me what you have?
And then can they bring me
With
one of
or
those?
without
That's
ice?
With the ice.
I like
With
where
the
both
ice. All right.
are at, yes.
And also a beer for Carrie.
One of those
Yes,
and
one
of
of
those.
yes.
Not a problem. I'll take care of it.
Thank you, Jason.
Thank you, Jason. We appreciate it.
So here's a question for you guys, and this will fill the time well, I think. Body cams. So I work.
It's a very good.
I work in a position in which I'm required to take as much information as I can and make sense of it, right? Actually, when you look at it, that's what EMS is. Take as much information as you can, make sense of it, and make an outcome. We're looking at things like video laryngoscopes. A lot of services have them, some services don't. And then when you get that VL, do you want it to record? A lot of police departments are going to body cams. Firefighters wear helmet cams when they fight fires. How far out is EMS from a video recording system?
I think as far as EMS goes, the biggest thing is that you're taking care of people. And so I think that's going to be the biggest hindrance to it. I'm not necessarily opposed, I guess, to the idea. I feel like there would be great benefits, but I think there could be great harm as well to people and their privacy and just the potential for the leaked information. And very private, very intimate things happen in the back of the ambulance. Yeah. And so I think that will be the biggest drawback for it.
Sure.
And perhaps part of the thing that jades our view up here in Minnesota and Wisconsin is how robust like our peer review protection privileges are. In other states, Minnesota and Wisconsin are two of only 12 states that have peer review protection for ambulances. But like in Florida, where they don't have that, they're probably further back. Mark?
I will differ a little bit from Dr. Haley. I think it's coming. I think we're already starting to see this. The LifePak 15 monitor has the ability to audio record. I know several services around the country that have used this and are using this to great benefit.
Famously, Seattle Medic 1,
yes.
And they attribute that to part of their success with resuscitation.
Yes.
Yeah.
Yes, because they can look at every resuscitation and they can score when medications are given, how the paramedic is.
Jeff. Sorry, I'm sorry. I don't mean to interrupt.
How the crew is doing. I think we're closer than most people think.
Yeah.
And when that trial comes, I still work on the street. You can put me down number one in line, I think. But I think I'm probably in the middle between the two of you. I think we're a long way out, and I think there would have to be a ton of, like, if you're doing a 12 lead, set your body cam on the counter and, like, put it away from the patient or something like that. Respect that patient's privacy as much as you can. I'd like to see audio recording a little bit more widely and openly available. I don't know where that lies.
I love that you opened that into the mic too.
It's great, right? It's perfect, right?
So I'll give you.
Boy, this is a boring question.
It's like a commercial.
I'll give you my medic opinion of that exact topic, and then we'll give it to Jeff and see what Jeff thinks about it. So my opinion is that I would be fine with it. I would be totally fine with it because I don't have anything to hide, and I think, and I don't want to speak for police and cops in general. Obviously, I have very good friends that are cops, but I think some departments have a drawback because you can take images a certain way, and it might put them in a position that might be vulnerable when it isn't necessarily vulnerable. We live in a very litigious society, unfortunately. So when you're recording, not only does it protect you, but it also opens you up to the possibility of something, happening that you didn't intend. But my opinion is that I don't have anything to hide in the back. And in fact, it can protect you in some instances, right? Mm-hmm. So you have a patient in the back of the ambulance, maybe a combative patient who is fighting with you or whatever might happen, or they go after the call and they go to a lawyer and they say, they did this to me, they said this, they said this.
Which probably happens a lot more often than people.
Yeah, I bet it does.
Yeah.
I bet it does. And Dr. C and Carrie, too, you might see this in your roles as medical direction, complaints that come from patients toward, that patients say that their medics did. This would eliminate that to a certain degree.
I know one of the former medical directors from San Antonio, they instituted turning in their life packs on all patients.
Whether they used it or not.
Yeah, whether they used it or not. And it was fascinating. They said they had their rate of patient complaints dropped precipitously because they had audio recordings of the way the patients were interacting with the crews. And it took away the, for better term, he said, she said, of what was going on. Mm-hmm. And I think audio recording probably well before video recording comes on. Yeah. But certain aspects of video recording, such as video laryngoscopy, will be coming. I think there's, whether we like it or not, Ultrasound is becoming much more affordable and usable, and
Boo.
I know your feelings on this, but it's becoming much more affordable. It is going to be used probably much more in the next 15, 20 years than it has been used ever before, because the price is coming down, the ability to transmit information is improving.
And you can still
come.
get really good quality imaging
Yes.
now at
There's-
these lower prices.
There's brilliant ultrasounds out there. I'll be super interested in ultrasounds when we can get past arguing with each other about whether or not patients should go on backboards. Then we can
Oh
start
my
talking
goodness.
about ultrasounds.
Before I give it to Jeff real quick, there's a statement that I just read on
Yeah.
Facebook.
Daniel Naylor.
Yeah, about the UK. It was like, you know, in the United Kingdom today, a physician and a paramedic did a crike in the middle of the street, and in America, we're wondering about if we should continue to put patients back on a backboard.
Yes.
And it's like, we're better than that in EMS. But before, real quick,
That's
Jeff,
my next question. So
we'll talk about that. Jeff, welcome back to the show.
Hey, thanks for having me.
How's it going, man?
I'm doing well. How are you?
Good. So Jeff was on our show to talk about pediatrics and EMS. Not an easy topic to talk about. And again, very successful episode. And we're going to kind of talk about that again, if you don't mind,
Sure.
once we get into some of our questions to the medical directors here. But first, thank you for being back.
Yeah, thanks for having
Are
me.
you happy to be back?
Absolutely.
Are you drinking?
Yes.
Is your wife drinking?
Yes.
Okay. Why are you shaking your head at me, Alex?
I don't know.
Oh, okay. All right. He doesn't know. He just
This is
shakes-
the medic assessment brought to you by ethyl alcohol.
Okay. Alex, why don't you go with a question for Jeff and the medical directors, and then I will follow it up.
Okay, I'm going to go ahead and put my feet on my soapbox here.
Okay.
So I just talked about backboards. We are in a time in EMS in which a number of the things that we do are very dogmatic, right? The thing that they always say about the fire service, which is true about EMS as well, is the centuries of tradition unimpeded by progress, right? And that's where we are today. When we go and look back at what our protocols looked like in 1990 and what they look like rapidly approaching 2020, the medications have changed. The way in which we focus on resuscitation has changed. But we still do a number of things that have shown negligible benefit and in some cases harm. So my question for you guys is twofold. One, which one disappears first? Pre-hospital intubation or pre-hospital spinal immobilization? And will either of them happen in the next 10 years? And I'm not saying that either of them need to be gotten rid of. I'm just wondering your thoughts. And question two is, when can we tip the scale on a national perspective? We're so lucky with how progressive we are here. That's not the case elsewhere in this country.
Jeff, you get to start on this one.
Your turn.
Boom! Right on this.
As far as the first part of your question, I would say backboarding would probably go out the window before pre-hospital intubation, I think.
Yeah.
I think just
I
with
agree.
the
I agree.
with the amount of video equipment we have for intubation now, it just helps so much. And honestly, I don't even remember the last time I backboarded somebody outside of a post-arrest.
Yeah.
So.
Yeah, just
For,
easier to carry.
for
on.
extrication.
Exactly.
I totally agree. Yeah. Dr. C, Carrie?
I would echo that. I think that backboards will leave
I'm just remembering the time when I was doing my residency in emergency medicine in Jacksonville, Florida, and was running with one of the ambulance crews, and we were literally chasing a guy down the street to put a backboard. I remember this.
I learned how to standing backboard in 2008.
So I agree with Jeff. The use of backboards will go first.
How about C-collars?
C-collars.
They don't hurt anybody.
Yeah, they can. Yes, they can.
They can in pediatrics.
They
Yeah.
can. Okay, so I'll put it to you this way. If you come to the accident scene and the person's turning their head to the left and they say, and you try to put in the midline, they say, no, that hurts.
Leave them alone.
Are we helping them or are we hurting them?
Right.
There's a reason that person is turning their head to the left. Okay?
I think most crews would have the presence of mind to go, I'm not going to touch that.
Yeah.
Yeah.
Okay.
I-
So that's one thing. I agree with Jeff. Endotracheal intubation will never go away. I make that prediction now on the thought. I make that prediction it will never go away. Will it be significantly limited? Yes.
And we're
Will we go to credentialing? And that's key. Credentialing of this skill. yeah, I think we're headed that way.
And we're seeing more and more restrictions under the protocols here in the East Metro. If you can't get their SATs above 93, they get a supraglottic airway. Under the protocols that you and I are currently working on, if you can't get their SATs above 90, they get a supraglottic airway. Okay, or if you don't think you can intubate them, you get a supraglottic. And that's not because I don't think that the crews can do it, or because we don't think that the crews can do it, but let's get people comfortable with the most routine of intubations. The 70-year-old that's not super kyphotic in cardiac arrest. Like, get good at those ones, and then we'll talk about the shotgun blast under the chin.
Yep.
So that ties me into the pediatric question, which I wanted to talk about. So, do your medics, Dr. Haley and Dr. C, still intubate kids?
No.
No.
Okay.
Okay.
With exception.
With exceptions for our
Yes,
critical
critical
care.
care.
Yes.
Critical care
Correct,
medics
yeah.
And
still
air.
Yeah.
Yep.
And air.
Yep,
Yep.
and air.
So Jeff and I both work at a service that is strictly critical care. All of our medics are critical care certified. Jeff is in the process of going through that class. I taught him some critical care concepts not long ago, like the oxyhemoglobin curve, and I threw the textbook across the room because I hate that curve so much. Anyways, so when was the last time, Jeff, as a paramedic, can you tell us that you intubated a kid?
Never.
Okay. So what are your backup airways for intubation, or I should say airway management in a kid?
Hi, Joe.
Okay.
All right. Which is fascinating because there are no studies, no nothing that says eye gels are abuse in PEDS patients. There's nothing there.
Yeah.
Absolutely nothing. But we've, like a lot of what we do in emergencies medicine, we said, this works for adults. Let's do it for kids too.
Right.
Okay. We've jumped into this.
And
Which
I
I
doubt
think-
there will ever be good evidence to say
No.
that this is the
No.
airway for kids. Nobody wants to do that study.
No.
Sure.
If anything comes out, it will be a retrospective study looking at saying, look, we had these kids and we put these in. But the revolution in supraglottic airways that have occurred over the last 25 years has been incredible. When I was training, we had the EOA.
I saw that at the Smithsonian.
The esophageal obturator.
I don't have the balls to say that.
You
Apparently Alex
laugh. You
does.
laugh. I go to some of these little BLS ambulances out in southwestern Minnesota, and I still find them, and I drive my truck over them.
There are likely still services using them.
I know.
mean,
Probably.
I know. And truly, if there was an instrument of the devil, that was one of his tools.
So, Dr. Haley and Dr. C, you have intubated children before in dire circumstances. How different is intubating a child than an adult, and what complications can kind of arise from it?
So I personally probably don't have as much experience as Dr. C with things, but in my experience, I found that it's sometimes just trickier to even identify where you are.
Sure.
Because they don't have the same structures that you are used to seeing necessarily. Sometimes they're way more anterior and they just don't look right. They don't look the same. They're more flesh colored. It's harder
Yep.
to identify.
Yeah.
So I think it's probably easy. And then once you put the tube in, it doesn't go down as far. So it's easier to get it dislodged.
Yeah.
Yep. And I will agree with all that. And one of the things I've done for years in our service is for all our new staff, I teach airway. That's the one thing I really concentrate on, airway. We talk a lot. We talk about kids. And one of the things you got to understand is how the airway and the anatomy changes as the child matures. Here's a real simple thing for everybody listening out there or listening to the podcast. If you have access to a child between the ages of 5 and 10, and they will trust you, have them open up their mouth real wide and say ah. In about half these kids, you'll see the epiglottis pop up right over the back of the tongue. And that gives you an idea exactly where it is. And one of the things I teach the medics is that back when we were intubating kids, is that your blade selection is critical. You have to select a blade the same way you would select an oropharyngeal airway for
Very
the
good
child.
point, yeah.
You use the same technique to do that. Because the most common thing, you wind up in the esophagus. And you're
Yeah.
like, well, where the hell am I?
Right.
Well,
The esophagus.
Yeah.
Esophagus.
Yes. I feel like it's very much more easier to go too deep
Sure.
with a kid than it is for an adult.
Absolutely, absolutely. And one of the things you always have to, one of the things you is the big, in adults, what do people do? I'm going to pick the biggest blade we have and we're going to go with it, right? Yeah.
Move as much stuff out of the way.
Move
Get
it.
all of that out of the
Yeah,
way.
come on. All right.
Yeah.
Give me that Mac 4. Give me that Miller 4.
They make
Okay.
fives
I'll
now.
just go with the D blade.
Yeah, it is. And you have to think much more critically about this.
So
So hang on. So I'll speak.
it's going to
just-
disappear.
Well, that's fine. That's your butterfly effect. Do you see his face? I can see it through my screen right now. It's just like, anyways. So I'll speak as a paramedic. I'll give it to Jeff real quick, and then we'll cut you loose if that's okay with you. And then you, just like Jason, gets the pick of the next medic to come in here.
Sure.
As long as, and we are totally using our guests at this point. If you could refill my glass on your way up, and maybe Dr. C's, I don't know.
I'm good.
Okay,
Okay, thanks.
So what I wanted to say was that. Well, now Alex threw me off with the butterfly effect. No. So, as a critical care paramedic who works with Dr. Haley very closely in our other medical direction, and Jeff as a soon-to-be critical care paramedic, I would argue that even though I have the ability and the autonomy to intubate a child, I'm almost always going to go to a supraclotic airway because unless there's a definitive anatomical reason why I need an ET tube, such as burns or things like that,
Yeah.
I just, it's so much more, it's way easier just to do a supraclotic airway, and it eliminates that process in a situation that is already chaotic,
Right.
that is
100%.
already really stressful.
I completely agree with you.
Yeah.
We looked, Alex helped me with this. We looked at our own service, and I think we were doing, about 18 pediatric intubations per year?
The number was 11.
with the amount of people in your service, is
Which
just,
we have
that's a
close to
super
700
small
providers.
percentage.
Yeah.
Close to that.
Yeah.
And we looked, who was doing the most of them? Well, our air service
Yeah.
was doing most of them.
Right.
Okay, which made sense. And so we were looking at the average street medic, or the average ground medic would be seeing a pediatric airway about once every 15 years.
Yeah, it was a 0.07 odds ratio.
Yeah,
And
I
it
was just, and there was when we took, we made the decision to take this away from some of our from our ground staff. Some of my older staff was very much against this. Why are you restricting this? And I asked several of them, when was the last time you put an endotracheal tube down a kid? Oh, years, but it's just like an adult. No, it's not.
Yeah.
No, it's not. So the consideration is this, and here's here's what we need to look at for this. Putting a piece of plastic down an airway is a procedure. Managing an airway is a skill.
Sure.
We want you to manage an airway.
Yeah.
Right.
Okay, that's what we want.
And
Yeah.
So sorry, Alex. I'm cutting him off. He's going to be so mad at me after this.
That's
so
not untrue.
I want to cut Jeff loose here. So Jeff, what's your thoughts if once you get your critical care certification, which I hope you're excited about?
Sure am.
I'm excited for you. How do you feel about innovation in the kid? Is it something that you're going to do, or do you feel more that you'll stick to what you know right now and kind of what we've talked about?
I think you kind of hit the nail on the head with your answer, saying it's just a supraglotic air is just going to be so much easier.
Yeah.
And you can throw it in, and it's just like, I got it, it's done. I don't have to worry about figuring out which blade I'm going to use, which tube is the right size, or anything like that. So if I can manage it like just fine like that, I'm good with that.
Yeah. Since the advent of the iGel, our use of endotracheal tubes went down. When we had the Kings, people liked to intubate because the King was just a miserable airway, right? In a number of circumstances, it works. There's a lot of services that use it, and that's fine. But comparatively, like when you look at the iGel, you set it and forget it.
Yeah.
There's a lot of good new airways out there. There's a lot of interesting new airways out there, like the Slippa and the Salt. But there's a lot.
That's
of
a rabbit hole that we.
Yeah, there's a lot of good airways out there. So I'll let Jeff go, and I can do some filler time.
Jeff, thank you for coming on the show. We appreciate you coming by and hanging out. And can I get a refill with that?
I got you.
Jeez, I appreciate it.
Thanks for having me.
Yeah, thanks for coming. We appreciate it. Go ahead, Al.
And I would say, as someone who practices out
you can
in
pick
more
any one
rural
of the guests.
areas and stuff,
Thanks
in all
for-
honesty, if I have a super sick kid, I might just throw in a supraglotic tube. I'm going to do the safest thing for the patient at the time that I see them.
Yeah.
Totally. And we're lucky here is that we kind of have a number of ports in the storm here in the Twin Cities. So you're not usually more than 15 or 20 minutes away from a hospital that has physicians that can come help you do that, you know. So what I was going to talk about with intubation, and I'm not anti-intubation. I'm anti-doing something we're not good at, okay? Jeff Jarvis, who's the medical director in Bexar County, Texas, is a tremendously cool guy. I believe they only do adult intubations, and they only have video laryngoscopy. And so they only have to practice with one device every time. And he requires that they practice. Mm-hmm. And his first pass success rate, the last I heard, was somewhere between 85 and 90%. Yes. Nationally, the number that I pulled for this from ASAP is 77.1%. That's not good enough, right? No. If we crashed the ambulance at a rate of 77.1% of the time we drive safely and the rest of the time we have accidents, we would look at what we were doing. We don't seem to do that as much with invasive airways. Sure. Yeah. So maybe the answer is practice and not just taking it away. Thoughts?
I would agree with that. But we all, this is a high risk, low volume procedure.
Right.
By definition, you don't do those very often. They have the highest capability for causing harm. So you either have to do it exactly what you want. You either have to practice a lot, which means you credential. Which means you have to do this on a set basis, and it can't be yearly. Yeah. You can't do this, come by and pass the test yearly. No.
And it can't just be Fred the Head.
Yeah. It can't be. It has to be. It has to be live tissue intubation.
So I'll kind of speak from both a paramedic's perspective and kind of an educator's perspective. Hey, Nick, how's it going, man? So for me, when I'm teaching new medics, new employees, RSI, for instance, and this is going to tie kind of into what we're talking about, innovation. Thank you, my good man. Yeah. No ice, though. I like it. Just straight. So one of the things that I teach to our new employees, and I know that Dr. Haley and our medical direction, which she knows very well, teach this too, is that it's important to know a skill like intubation and RSI, for instance, and when to take away somebody's airway. But more importantly for me as a clinician is knowing when not to do it. Absolutely. When are the important times when you shouldn't be intubating, when it's a difficult airway, when there's, thinking 10 steps down the line and not just utilizing a skill such as intubation and RSI just because you have it in your toolbox. And I think as paramedics across the country, that's something that we need to grow and get better at, that we have all these really advanced tools, but part of being a true clinician is knowing when to use them, when not to use them, doing good assessment techniques, being able to manage an airway by itself with, more simple techniques. And welcome to the show, Nick. Yeah. Thanks for stopping by. Yeah. So that's what I would say about innovation. And Nick also works as an FTO, and he also works as a preceptor, so he could probably chime in on how do you feel about innovation in the pre-hospital setting?
I think it's an important skill, and I think it's something that's good for us to, I see a lot of cardiac arrests where people jump right to the supraglottics.
Higher survivability in almost every study.
Which I like. Yeah. But I think that it also gives us the ability to lose a little bit of our skill with intubations.
Absolutely. Yeah. I still always look.
Yeah. And, I think it's important to, keep up that muscle memory to be able to get in there and take a look. Especially with technology now, the CMAX, pocket CMAX, which we have now, I think have really made things much easier. Yeah. Teaching ACLS today, we talked a lot about that angle of view with the CMAX and just what it brings to you and how much easier it is to intubate. Yeah. I know I've had some intubations in the last 6 months where I don't know if I would have got them without that CMAC. Yeah. So I think new technology has really pushed that forward. Supraglottics are great, though. Yeah. It's kind of that safety feature you have in your back pocket. And
GlideScope even just came out with a new video laryngoscope for EMS. So I mean, there's more and more coming out, which means they're going to get better and better.
And so I'm going to turn this question back to both to Nick and Greg on this. You talk about both being preceptors, FTOs,
I'll
teaching
stand by.
people. Yeah.
Alex is excluded.
Yeah, Alex is excluded. I think you. How did you do? You are racing.
I'm an administrative racing professional.
That's a racing.
Okay.
Yes, I did. I have listened to all the podcasts. And so here's my thoughts. How do you teach that newer medic to have the experience that an older medic has? How do you do that?
I'm going to defer to Nick because Nick is more a senior than I am in terms of experience.
And so how do you give that acumen, that experience? How would you do it?
That's tough. I mean, I've been doing it for 21 years, and
You look great.
Yeah, of course. Gray hairs are covered up by this, right? You know, that experience you can't teach.
Yes.
You can teach comfort and calmness.
Yes.
And as I talked today to some of our people, you talk about slow is smooth and smooth is fast.
Yes.
And that is something where take a deep breath, think your way through these things, and understand there's going to be times where you're going to question yourself.
Yeah.
And don't get overwhelmed. You know, there's going to be a lot of stuff that's overwhelming, but understand that's natural. Being in these calls, the really intense calls, these really sick patients, understanding that you're going to feel overwhelmed, but you can look back on that and say, you know what, I think it went well. Being able to look back on it and, review it with yourself, but you can't really second guess too much. I mean, you go with your instincts, moving through that patient, and it all comes with experience.
Right, and that brings us back to experience. Let's. I've actually been in this game a bit longer than you have. Okay, so, just a bit. Okay, but the consideration is this: is you have you have a newer medic. They have been taught this skill. Everybody wants to take the bright and shiny tool out of the box.
Oh, yeah.
Okay,
You want to do the most fun thing.
Yeah.
Yes, you
It's
do.
very exciting.
You do. Okay. It's hard to teach people that just because you can do something doesn't mean you should.
Absolutely.
That's just a good life lesson.
And so that's one of the things that Alex and I worked at in our service is having a clinical decision tool for when you should intubate.
Yep.
When you should go to, we call it MAM, medically assisted airway management. I have a problem with rapid sequence induction because there's nothing rapid about
rapid,
it.
yeah.
No,
Yeah.
there's nothing
Right.
rapid about it.
Or
Okay?
intubation, because that doesn't need to be your end game.
Right.
Yes.
Right.
So you're doing medically assisted airway management. So the consideration is how do you teach that patient selection, right?
Mm-hmm.
The situational awareness. How far are you from another place that can manage this airway? Is this the airway you need? Okay. So those are hard. Those are hard. And I'll turn it back one more time. How well do you think our paramedic schools are preparing these people to look at that?
So that's exactly actually what I'm going to kind of talk about. So as my goal as a preceptor and as an FTO in the EMS setting, I tell this to every single person that comes through and I try to educate. It's not our job and Nick and mine's job as FTOs to make paramedics and new students mimic what we do, right?
Agreed.
The trait of a good educator is giving individuals the tools to be themselves, right?
Yep.
I don't want somebody to mimic what I'm doing as a clinician. I want you to be yourself and figure it out on your own. And I think the more autonomy that you give to paramedics, the more likely they are to clinically look at a situation such as intubation and have more of an approach to it than just mimicking what somebody else is doing or going to school and learning the skill. And it's like, a cookie cutter medic. Like, this is on the algorithm, so I have to do this next.
Okay.
So the more autonomy that I can give new medics and new students, I believe that overall it makes them better, and I think it makes them better in this circumstance where we're talking about innovating and not innovating.
So,
Go ahead.
And I think that it's something that we see as we get these students that come through. We're just about to get another group of students come through, and we see these people come through, and I'm like, do you even really know this is what you want to do? Mm-hmm. So there's been the time where we had people who you'd spend some time on an ambulance, you figured out, yep, this is what I want to do. I'm going to go back to school to be a paramedic. And now they can jump right from EMT to these interventions type courses right into paramedic school. They maybe haven't rode a day on an ambulance.
Yeah.
Right.
And all of a sudden they show up on an ambulance in medic school and their eyes are like dinner plates. It's like,
Good.
holy buckets.
holy buckets.
Yeah.
So, Dave Barrett, who's a local educator, made two very good points here. And Dave's a tremendous educator as well. So,
What's up, Dave?
Hey, Dave.
What
I
he's-
worked with Dave when he was. I worked with Dave at Century.
Yep. He said we train on a continuum of airway management. At the least, patient manages their own airway, and at the top, surgical. So I think of it as you have to go into paramedic school with your own toolbox. Whether your toolbox is full or empty, paramedic school is going to give you the tools, and then FTO is how you take those tools out of the box and fix the broken board.
Yeah.
Yep.
And so autonomy, I agree with Greg. The more autonomy, the better. I work at two services that give us a tremendous amount. Make your own decisions, back them up. But there will always be the 2 a.m. call in a 24-hour where you can fall back on that algorithm, and that has to be there.
Yeah. Let's look at a profession that. Let's look at a medical profession that addressed airway management very aggressively, and that's anesthesia.
Mm-hmm.
That's their whole thing.
That is their whole thing.
Yeah.
They have, they have algorithms on how to manage every airway. Anesthesia went from a profession that had one of the highest malpractice claim rates.
Yeah. Awareness
Right.
cases.
To down to one of the lower ones, close to family practice.
Yeah.
I mean, really, how did they do this? They did this looking and setting up guidelines nationally, doing algorithms and saying. Now, granted, their algorithm, most of their algorithms say airway's too difficult, go back and bring the patient back again.
Mm-hmm.
Yeah, we don't have that option.
Try again next time.
That's not there.
Yeah.
But the consideration is, and Nick, that's one of the things I want to think about is getting, that acumen that you and Greg and Alex have had for years doing this, getting them to understand when they need to do it, why they need to do it,
Yeah, totally.
and the pitfalls. And more importantly, when they do it, as Nick, you said, being prepared.
Right.
I'm not rushing into it, but being prepared and realizing that this is a choreographed procedure.
Go ahead, Dr.
Oh, no.
Haley.
No.
So I was going to say one thing, and then I had a question for Dr. Haley, actually. So Nick and I were actually just having this similar conversation with a senior leader at the organization that we work for. And this person was talking about how people are going from getting their associates or bachelors right into getting their masters, right into that kind of next phase of life without getting any life experience. And I think, and he asked the question to us is what happens if your boss is suddenly somebody who has all these, education, certifications and a master's and a doctorate or whatever, but has no life experience? How would you take that? And I think our response, both Nick and I, was like, that would be really difficult. That would be hard, because how can you be in a position of a leader, and as a paramedic or a doctor, whatever it might be, you're a leader in that circumstance. How are you able to do that if you have zero life experience? And I think the best clinicians across the board, medics, nurses, PAs, everybody, are those that come from a variety of backgrounds that have a lot of life experience. And I think that's more of a trend in today's society. It's like, I can't get a job with a bachelor's, I'm just going to go get my master's, I'm going to get my doctorate. And it's like that piece is missing right now in our education system. And I think we see it too as paramedics. It's like, people go to medic school and that's it, and they haven't done anything else. And it's like, that limits you in your ability to perform well in medicine across the board. Dr. Haley, what do you think?
I completely agree with that. I mean, even like going through the training for like the physician training, so many, I mean, I'm guilty. I almost went straight through, but there's the gaining, you learn so much just by experiencing, especially clinically. So getting into your clinical, maybe doing EMT for a year or two before you go to medical school, because there's so much to learn about the interpersonal portion of medicine, especially pre-hospital, where it's like you're in their house, you're with their family, and you need those really important interpersonal skills that you don't necessarily get out of a textbook.
Yeah, absolutely. Yeah.
And there's that patient assessment. I had no affiliation with EMS, zero, until I got to my emergency medicine residency. Zero. So I am not fellowship trained. Okay. I have passed my EMS subspecialty boards, and I did submit my application for Fellow of Academic Emergency Medicine, or EMS. But I was not one of those people. I did not have any of that experience, and to me, that was really tough. And during my residency, what I did is I was the weird guy in emergency medicine who did more of the street call than I was supposed to do. Sure. They'd say, hey, we need a doc to do street call with damn it, I'll do it. And I had to, because
2 a.m. gas station hot dogs.
Yeah. It was an uncomfortable situation for me.
Yeah.
And I realized the only way to get through that uncomfortable situation was to experience it more and get the experience.
So Alex, I'm gonna give it back to you real quick. He's looking at me again for another question, but I want to let Nick go, and we're gonna excuse you if that's okay for another guest. We'll get in here, but Nick, again, thank you for being on the podcast. We didn't talk a lot about the tactical stuff, which was your episode with Mark, but we'll bring you back on, both you and Mark, because I know there is a ton of stuff you want to talk about in regards to tactical medicine. Which, again, that episode was really popular because I think it's something people don't know about. So
can we do more than 15 minutes next time?
Absolutely.
That's what it felt like, was about 15 minutes.
So the last time that you were here, you brought helmets for Alex, and Alex was not here because he was at Comic-Con. So I think that, Alex hasn't worn a helmet yet tonight. So
right.
Dr. C, Dr. Haley, what do you think? I think it's time.
I don't. So just, Nick, for you, as time goes on, ASAP just released a position paper supporting tactical EMS. So if you need it, let me know. I'll send it off to you.
Absolutely. I love it.
But it offers a lot of support for what you guys are doing out there, and it really offers that recognition. So
yeah, I would love it. We have a ton of... We actually have a reading list of a bunch of different articles that I get on a regular basis. So it's always very good to read. And, I think if you're not constantly reading new things, you're going to fall behind. So.
Yeah.
So,
all right, thank you.
Thanks for coming. Go grab one of the other guests. I know there's a couple out there that haven't been in here yet, so you pick.
All right.
Who comes in next?
So I will say, Greg, and this has been a hotly contested point between the two of us. I went straight through. I took a year-long internship similar to interventions. I didn't go to the school in which we're talking about interventions, and that's why they developed it.
Oh, sure, yeah.
I turned out okay. I'm the co-host of
his voice escalated as he said that.
I'm
I turned out okay. Oh, sorry.
I'm the co-host of a pretty successful paramedic podcast. Stuff like that.
It's okay.
It all depends on the person. If you put the time in, you put the work in, you're going to be fine.
Yeah.
Okay. I just finished my bachelor's, and I'm going to go right into a master's program. I have 5 years of admin experience, but it all depends on the person. So if you're new to the business and you're struggling a little bit, it's okay to take a step back and say, I got to learn a few more things about myself and about just being an adult and working in this business before I go on. It's okay to do that, but it'll happen.
So Dr. C and Dr. Haley, I have a next question to kind of piggyback off of that. Have you ever been in the position of a paramedic who maybe you're transferring a patient to, or maybe is in care of somebody that maybe you're overseeing, that you didn't feel comfortable with that paramedic taking care of them? And if you did, what were your course of actions, and how did you approach it?
So I have been in that situation.
You don't have to use names.
Yep, no, I have been in that situation. I think the biggest thing from my side of things, especially working in a smaller hospital most of the time, is that I'll just keep them there a little bit longer just to make sure they're extra stable before they go.
Get them over the hump.
Yeah, or if I can't get them over the hump, just knowing that, hey, I'm transferring care to someone who's going to be by themselves in the back of an ambulance, driving for who knows how long, depending on the weather. Let's try to optimize them instead of doing a lot of, lots of times it's the rush out, get them out of here, they shouldn't be here.
Yeah.
But why did you come here?
That never happens.
But it's really good, I think, to take a step back and be like, okay, I have myself, I have at least a couple other people here with me. Let's make them as stable as possible before moving on to the next phase.
Yeah. Dr.
So
C?
it's interesting because I'm at the other end. I'm the one who's receiving the patients that Dr. Haley is sending.
Yeah, you don't do a lot of transfers.
No, I don't do a lot of transfers, and so I'm receiving. So the consideration is, but I also get calls. I'll get paged to say, call so and so at this branch because they have the patient they want to transfer. And it's fascinating. It's actually rarely that I have the medic that is uncomfortable. If that is true, usually what I do is I give very specific instructions. If this, do this. If this, do this. If this happens, do this. If you are lost, here is my cell phone and you will call me. Okay? That's what I found, and I just had a call about this Monday, or was it Thursday morning. I had a patient who was at a small hospital in Wisconsin who was horribly mismanaged, and the medic was being asked to transfer in an hour and a half by ground.
Sure. Yeah.
And the patient was being horribly mismanaged, and when I told the medic, I said, you need to have that physician call a helicopter because you do not deserve to be in the back of the ambulance with the patient that they have horribly mismanaged. And so
it's like a 2-hour ground trip.
Yeah, and here's the thing. Even if you're at a small hospital, you have staff.
Yep, you have
way
more resources.
You have space, you have more resources. In the back of the ambulance, usually there is one person. That person has to be maximally stabilized. It's one of the things I actually talk to our air crews about. Even though that they have 2 people in the back, they're working in a really small space.
Sure.
If the air crews had a space the size of this room, they'd be ecstatic. Okay?
A way bigger helipad.
They would. They'd be ecstatic. They would. But the consideration is what we talk about is exactly what Dr. Haley talked about, is you maximize the patient before you do that.
So before we welcome our next guest, Matt, how's it going, man?
Good.
So before we welcome our next guest, we just say the words before we welcome our next guest.
Well, it's making fun of me. It isn't a podcast until Alex makes fun of me at least once. So I wanted to ask a question to both of our doctors, and then I'm going to get into some questions for Matt. So what do your counterparts in medicine, such as other physicians that don't work in EMS, what are their opinions of paramedics? Dr. Haley, you're already laughing, so you're going to go first. And
read
then
between the lines on that one.
Well, I think that there are a lot of misconceptions. I don't know how strong some EMS experiences were in other residencies. I think it can be very robust, and I think it can be very limited. And I think that sometimes people might even skip some of them.
Yeah.
So I think there's just a really huge misunderstanding about the amount of education and knowledge that paramedics do have.
Sure.
Especially experience-wise, in dealing with sometimes a lot more difficult situations than we deal with in the emergency department. And just kind of a bias because of that misunderstanding.
Dr. Haley was so incredibly diplomatic. I had to engage my lip lock in order to say certain things. For years, one of the most common comments I got from my partners was, "Do you know what your paramedics did?" And my standard response was, I don't own any paramedics.
My reply is always no, but I'll get a pen.
We know which person that is for.
Yeah,
yes.
yeah.
And so that was always my standard response. And they would give me a litany of things. And I said, how many years of training do you have? How many years have you been doing this?
Mm-hmm.
Can I put you in the back of the ambulance with this patient and these resources and you do the same job? So that is one of the things I always is Dr. Haley was so much more diplomatic. But the consideration is this: there is boy, I'm going to get myself in trouble.
I'll cut you off. I'm going to do your favor.
No, I'm going to say it. Many of my partners are willfully ignorant of what happens, what's going on, and what resources are available.
Sure.
So there we go.
So I'm gonna give it to Matt here. So again, welcome Matt for coming back to the show.
Thank you.
Thanks for being here.
Glad to be invited.
We were very excited to have you on the first time. We're excited to have you back. You want to come back for season 2?
Absolutely.
All right, awesome.
Mm-hmm.
So
Can you bring your chickens?
If I get more by then.
Yeah, his chickens were destroyed
I
by
know,
an owl.
But I know he's going to get more. Mandy's in the next room, right? She's listening. Mandy, we need more chickens.
So let me give it to you. Have you ever, and I know what your answer is going to be to this, but have you ever been talked down to by another higher level provider in your career? You have much more experience than I do, and how is your approach to it, and how do you feel about it now in your job?
My answer would be different if you asked me my first half of my career versus second, because it's 17 years long. In the first half, I was a hot-headed young person that probably would have put my foot in my mouth. The one that does come to mind, thankfully, was in the second half of my career, and I stayed calm, cool, collected, and I ended up proving my case. So I was really happy about that.
Yeah, with a doctor or whoever.
With a doc,
yeah. Does being called an EMT bother you?
No longer. Where I'm at right now, currently, no.
I love being called an ambulance driver because it conveys so much less authority.
Well, and then your expectations are so much lower.
Yeah, this is true. So.
How were the ambulance drivers to you today? Oh, they were great. How are the paramedics to you today? I don't know. Yeah, exactly.
I don't know. Yeah.
But the ambulance drivers, we got there safely and in one piece.
Yep.
I would totally agree. Early on in my career, I was like, I'm not an EMT. I'm a paramedic. And now, after doing it for more than 10 years, I'm like, yeah, that's fine. It doesn't affect me at all.
A little bit, though, it depends on who says it.
Right. I suppose, yeah, totally right.
We took them to the hospital.
If your ICU nurse says that to you,
that's true. So, Dr. Haley, would you ever correct another doc who's like, oh, those EMTs or those ambulance drivers are just did a whatever job? Would you ever be like, excuse me, they're paramedics?
That's situational.
Yeah. It is definitely situational. I think for the most part, I would probably just say, just so you know, they are paramedics. There's a difference, but
to your point, there's a really good EMS experience portion to both the East Metro EM residency and the West Metro EM residency here in the Twin Cities. They do a ton of time on ambulances and in some cases also fly. So we're pretty lucky here. I've definitely been talked down to, and to Matt's point, there have been a number of times where I've been like, well, hang on just a second, roll up my sleeves and come up with something snarky to say back. Mm-hmm. But now sometimes it makes me think a little bit too, to be like, maybe I did, okay, you're right. I brought you bring the trauma in without the IV and you get a bunch of grief for it. And you're like, well, fair.
Yeah. When you get proved wrong.
Yeah.
It's ammo. Oh, yeah. It's ammo to be a better paramedic.
Absolutely.
Yeah.
So, and if you give up on trying to be better, you should give up on the profession.
Yeah.
So I love that comment that you made, Matt. So and again, I'm going to ask the same question to you, Matt, that I asked to some of our other guests. You okay over there, Mark?
Yep,
good.
I'm good.
No, only you are hot, Alex. Just you're the only one sweating. So, what do paramedics come up with shared in their understanding of medicine, and where can they improve? How would you answer that question?
I like when we did the critical care training and the when we followed around the ICU staff. I like how I became more all-encompassing with what I'm doing in the back of the truck. It's not just to get them there. Let's make this an experience so that the patient gets better.
Yeah.
In the long run, quicker.
Yeah.
So
I totally agree.
that would be my best answer, is to be all-encompassing with their healthcare, not just that 20 minutes.
What do you think we do not so well?
Truck checks.
Putting you on the
Gosh, I don't know.
It's a tough
Really, if
question.
I'm just blurt out, the first thing that came to my head, bedside manner. I wish people were a little more
Totally
cordial,
And-
nicer.
Totally agree.
I think I said this on our last time you were on too. You are exemplary for bedside manner. Truly, in my 10 years of career and working with you for 5 of them, nothing gets you down. You're one of the most pleasant people on scenes.
I appreciate that. Thank you.
Yeah, and also it's the sweater. Matt wears this really tremendous postman sweater, and it just really does something to the atmosphere in the room. You're just like, yeah,
It did. It changed me. I could pull that thing tight and just crawl into my own.
I'll definitely piggyback on that. And I didn't say this to Jason, but Jason and Matt and Nick and my senior medics at the organization that we work for have really guided me along the course of my career. Because like Matt, too, early on in my career, I was definitely the same way. Very hot-headed, very like, I know this, I'm in, whatever it might be. And it took my senior medics to really kind of take me down a peg or two and have, thinner skin in that regard and being humble that you're proven wrong, like you said, which I think a lot of medics fail to acknowledge when they're wrong.
Yeah.
Because it's a very type A personality. It's a very like, I'm right, whatever it might be. Even in their head, if they know that they're wrong, they don't want to admit it. And I think part of being an advanced clinician, part of being in this job for as long as you and Jason and Nick and everybody has been, is being able to be humble and looking at your own faults and therefore changing and evolving as the years go on.
yeah.
We all have areas that we are uncomfortable. We do. We all have areas. I will admit, I do a lot in emergency medicine. I have one area that I am so uncomfortable at is I hate delivering babies.
Oh man, me too.
I feel like that's
I
universal in most
crack.
emergency medicine.
I will crack somebody's chest. I will do a burr hole blindfolded before I will do. Okay, but here's what you got to do. You got to find that area where you're uncomfortable. You got to go there. You've got to go there. You don't avoid it. You've got to go. That's the only way you will change. You've got to go to that uncomfortable area and conquer it. That's it.
Yeah.
So,
Where can I birth a baby then? I've been trying for 17 years and I haven't birthed a baby yet.
I've delivered one, and it was like the most awkward thing for me because I'm like, I know how to do this. I know how to do this. I know how to do this. And then eventually a switch flipped in my head where like, this has been happening for millions of years.
You're not necessary.
So I've delivered 2 children, one in my job, and then I delivered Audrey, my child. Our OBGYN was nice enough to let me be the one that was there to deliver, and that was fantastic. My wife was other opinion about it. Anyways, and the one child that I did deliver in the field, I did zero work, let me tell you. The mom did everything. I'm just basically, here we go. Oh, yay, whatever. So, I don't know.
And you even offer to let somebody else cut the cord. Like the one tactile step you have to. He's like, do you want to cut this cord? Couple of questions. And guys, those of you watching, if you have questions for Dr. Conrado, Dr. Haley, Greg, or Alex, please put them on Facebook. Andrew asks when we're going to do a show on PTSD and EMS. Andrew, I would encourage you to check episode 2 with Lynn or the episode with Jason, which was titled 30 Years in EMS. There are some good points there. It's a topic that will never go away that we'll always talk about.
So I actually want to piggyback on that to both Dr. C and Dr. Haley. Is there PTSD or burnout for physicians too?
Oh, for sure.
Yeah?
Yeah, I think so. I mean, I'm not very far in my career, and sometimes I feel like I have PTSD from some experience. But I've read a couple articles on it, and a lot of it has to do, like, you have the big major traumas, that are extremely, like, gut-wrenching. It tears at your soul. But it's the thing that really seems to contribute a lot to the burnout portion of things seems to be more like the micro traumas. So those small conflicts, those small interactions that just kind of eat away at you slowly. And I think that's harder to mitigate. I don't really know there's a great solution for those micro traumas to really combat, because that contribute to the whole of PTSD.
The discomfort with every patient on every shift, right? So seeing people in pain over and over and over again, seeing people with even minor traumatic injuries over and over and over again is what you're referring to, yeah?
Yep.
Totally agree.
And one of the things you have to understand is PTSD is not just one big event. It is the iceberg that's breaking away from the ice shelf. It is continual small things that build up, and that's what does it.
So Dave,
I'm just going to finish.
Oh yeah, absolutely.
I've had 6 people die in front of me. I've had 6 people die as I was talking to them. I remember every one of them. I remember every one of their conditions. I remember every one of their faces, and I will remember that to the day I die, or until I go senile. One of the two.
So next week,
Alex can probably give you a better
has really some kahunas here. Into his medical director like that.
look, as an aside,
but the thing is what do you do with that lesson?
Yeah,
that person has taught you a lesson. I've learned how to deal with it myself. I call them ghosts. They're the ghosts.
Mm-hmm.
They're the ghosts who sit on your shoulder and tap you on the shoulder and say, "Hey, remember me? You saw this before." That's the way I look at it.
I suppose a way of dealing with those kind of tragedies that we've all seen, myself, Matt, Dr. C, Dr. Haley, and Alex, is learning from those experiences.
Yes.
How can we better the next patient that we see?
Don't dump that experience. Don't force it down.
Yeah.
Look at it.
yeah,
And if you want to say analyze it. Look at it.
Face it.
And face it. Think of that. And take away a lesson from there.
you have to let it be part of your story
Yes,
as
I
a
agree.
provider. As an aside, because I do give Dr. Contrato a large ration of grief, everybody at work refers to him as Alex's dad. Okay,
I can see it.
yeah,
I'm okay with that.
Dr. Contrato.
I'm okay with that.
My significant other is in the next room, and Dr. Contrato is still number 1 on my text list. Like, it's just so I know which things to not talk about.
Yeah.
So hang on, Alex. I'm gonna give a question to Matt that Dave Barrett asked. If that's okay with you.
That's what I was gonna do. So,
Okay, well
yeah.
then just okay, sorry. I apologize. So Matt, Dave Barrett asks around the room, but we're gonna direct it at you first, and then we'll cut you loose. What's up, Dave? Yeah. So what is the number one stressor in the EMS career? If you could narrow it down to one thing, what do you think is the most stressful part of our job?
Again, the first thing that comes to my mind, and this might be service specific, is maybe the hours.
Sure.
The longer hours, the weekends, the nights.
Yeah.
Everybody else is off with family. I'm working. With my particular schedule, it's 3 days a week. I don't see my kids. I don't see my wife.
Yeah.
It gets a little bit hard for me.
Absolutely.
So,
Dr. Haley, what do you think is the most stressful thing for paramedics from your perspective as a medical director?
Or even as an EM doc.
Yeah.
I think that's a great answer with the hours. I mean, there's so much of life that you do miss with our careers.
can I ask,
Yeah.
how many hours do docs put in each week? I can imagine it's probably more than mine, isn't it? I put in 48. How many do you?
It really depends on the week. I, in general, clinically work about 130 to 140 hours a month,
Okay.
kind of
Okay.
spread out, and
Yeah.
then do probably additional 20 to 30 EMS
With-
stuff.
Outside of being in the ER?
Yeah.
That's
So-
a lot.
All right.
It's
So
good.
technically, I am contracted by my organization for 1,000 hours of EMS time per year. And I am considered a senior physician. So I am contracted for 700 hours of ED time per year. I know I do more on both sides. Okay, that's easy.
Yeah.
All right. That's easy. So I've considered half-time EMS, half-time ED.
Mm-hmm.
Don't ask me how 1,000 hours of EMS equals 700 hours. I mean, I still haven't figured out the math.
That's the documentation.
But the consideration is for the paramedics. I think to me, it's constantly seen. It's the hours. Mm-hmm. I agree. It's hard to do that. The second thing is constantly being that front line of patients. You are the front line. You're seeing patients at their worst. You are sometimes walking into the worst situations, sometimes the things that you probably dread the most. And you are walking, and you don't have a choice. You don't have a choice to say no. That's got to be hard.
Yeah. And then sitting in the fishbowl of everyone telling you what you did or didn't do.
And second guessing you.
That's mine. It's the what if. So the what if is the best part of the job. Like you put on your uniform, like, I wonder what's going to happen today.
It's the converse that sort of, I think, maybe attracted all of us probably to this craziness.
Yeah, so it's the best and worst part of the jobs, because after that critical call, and if in the public, you probably don't realize, like, usually after a critical call, you have to go back to base and restock, or you have to go drop a first responder back off at their station. So you have a half an hour in the ambulance to talk to your partner, or to sit quietly and stew and be like, God, what if I would have gotten that first IV? Or what if I would have intubated sooner? Or what if I would have started pacing sooner? The what if is probably what's killed me the most in my career.
Sure.
And I think in my role now, it's probably what's made me the most effective.
So I'm going to give you a little bit more credit than you're giving yourself. So I would argue that a good clinician, docs included, everybody included, is that the more that you question yourself and you're more like, I should have done this, and you're more critical on yourself, the less complacent you are in medicine. And the less complacent you are, the more that you're learning, and the better that you're getting at your job. Because I'm just like you, Alex. In the same regard, I used to do that too. I was very hard on myself. I was like, I should have been, and I still am to this day. But my perspective on it has changed, because early on, being hard on myself was like, it's just, I'm not good enough for this job. I'm not good enough to be a paramedic. And now I've kind of gained some experience with the help of my senior medics to know that that's better to analyze yourself that way so that you can get better. Because how do we get better at our job? We fix our mistakes. We fix the things that we're not good at, and we grow from that. So.
As long as you don't overanalyze.
Yes.
Absolutely.
I totally agree, yeah. So, Matt, we're going to cut you loose, if that's okay.
Absolutely, thank you.
Yeah, thanks for coming by. We appreciate it. Oh, absolutely. Yeah, for sure.
Great.
Go ahead.
No, go ahead.
No, go ahead.
No, that's fine.
No, go ahead.
I was going to start hitting filler time.
No. Well,
thank you.
Let's cut you loose. I think we have a couple more guests out there that we can pull in here real quick, and then we'll kind of start to wrap it up.
Absolutely.
But thank you, Matt. You can pick who comes in next.
Thank you.
So, a couple of things. Dave Barrett, again. Talked about Jeffrey Mitchell, who's the medic in Baltimore who invented CISM for EMS, which has some research to suggest it's very positive, some research to suggest it's not that great, but it exists. And he said that all EMS providers identified that hassles with management is their number one stressor. And with that, good night.
Oh, goodness.
So
I leave it to you, Alex.
So Louisa asks, what's our go-to de-stressor? I'll go first, because I never get to go first. I keep street clothes in my car, and if I have a really, really bad shift that I just can't get past...
Who needs a beer?
I do. I need a drink, actually. Keep
you
talking.
Need a drink.
I do, if that's okay.
Okay.
I hate to put you.
If I have a really bad shift...
And I put my order in for the same thing.
Okay.
With ice.
You?
I'm good.
Alex?
No, thank you.
Oh.
Thanks, Lynn.
I change into street clothes and drive home in my street clothes. Now, I like to drive to work in uniform because I think it statistically reduces my chance of getting a speeding ticket. But after those bad shifts, I swap back into Alex mode, and I take the time of my drive home, which on my part-time job is 9 minutes, and from my full-time job is an hour and 15 minutes. I take that time to, by the time I get home, be like the best dog dad I can be and not worry about the call. Mark, what's your go-to de-stressor?
Well, one of the things I do is I never wear scrubs to or from work.
Yeah, no scrubs, TLC.
I never wear scrubs.
Did you say TMI?
TLC.
Oh, okay.
Is in the song?
Yeah.
Oh, goodness.
I never wear scrubs to and from work. And I agree with Alex. There is something psychologically where you take off the scrubs, you take off the white coat, you shed your skin.
Yeah.
You do. You shed your skin and you become a different person. I mean, I think my personality as at work versus outside of work is very different. It really is. It's like I have this alter ego I get to let go at work. I do. It's kind of fun. So so that is part of it. But for de-stressing, one of the things I do is even though I drive a work vehicle and my EMS radio is on the way back to and from work. Yeah. Which is always kind of fun as you roll in and tell the charge nurse, "Oh, by the way, you're going to get a really bad trauma in about 10 minutes. Just wanted to let you know." And but I'll play music. I'll actively try to put what my shift was just like behind me. That's what I try to do.
So one of our commenters says that their go-to way to de-stress after a call or a shift is to go to the gym and hit the punching bag for an hour, which I would agree with. I think working out definitely helps with stress in EMS. I'm not as fit as I probably should be, but that is definitely a de-stressor.
You're sitting across from me. Give it a rest.
Okay, let's.
How about you, Dr. Haley? What do you do?
I mean, the biggest thing for me is just switching to mom mode. So I'm at work. I'm doctor. When I'm home, I'm not. I'm mom. I'm get puked on. I get pooped on.
You get pooped and puked on at work.
Yeah, I was going to say that happens at work too.
As well. It's usually a little less disgusting at home, in all honesty. But just going into mom mode for me is it's just completely different. Yeah. My personality doesn't really change as much, I guess, between my work and my personal life, but definitely the whole mindset. I don't try to think about work when I'm at home.
So one of the things that I do at work, and my wife will tell you this, and what some of my regular partners like Chad, who's not here tonight, will tell you this, is that when Audrey was little and she was a kid and she obviously poops and all that kind of stuff, I could always deal with Audrey's poop. And we're going to talk about this because Lynn is now a nurse, which deals a lot with poop.
Great segue.
Yeah, great segue.
The poop portion.
But I could, Audrey in that regard never bothered me. But I have a standing thing at work, which is if we and my partner ever go to a really poopy call, if my partner writes that call or they're the lead of that call, I swear to God, I will write every single call for the rest of that shift.
Yeah, it's eyeballing.
If not the next shift really too. Because it's my kryptonite. I don't know what it is. I could never be a nurse, and I love my nurses. I give them all the credit in the world. I can never do it, or a doc for that matter. You deal with poop. I
can't even deal with my dog's poop.
So, Lynn,
yeah.
Hi. Welcome, Lynn.
Yes. Thanks for being here.
Thanks. Yeah. First of all, I need to ask: have you actually ever watched the Kimmy whatever show?
Unbreakable Kimmy Schmidt? Yeah, I'm through season 2.
I want to. Well, I guess.
No.
Have you not watched it?
I watched a couple episodes from the first season.
You didn't like it?
I was betting out there. I was like, those guys did not
No,
watch
I'm through season 2.
They did not.
Yeah, so I'm through the episode where Titus does lemonade.
Okay, he knows more than I do.
Yeah.
He knows more than I do.
Active watching.
The question is do you like that show?
It's okay.
Oh, see, now I'm... Yeah, okay.
Sorry.
No, it's all right.
It's all right.
It's
not my go-to.
That's not for everyone.
Yeah. Everybody's entitled to their own opinion.
I'm super
you're just
into
wrong.
the... what is the show called? Westworld.
Oh, that's a good show.
Okay. Thank God.
So
have you watched that one?
I haven't watched that one.
That's fantastic.
My oldest son has said you got to watch this.
Yeah,
it's about robots.
Super good.
Right?
Yes,
Super good.
I remember the original Westworld with Yul Brynner.
I didn't know there was an original.
It was
it's not very good, though. Sorry, Dr. Seuss. It's not very good.
It was a nightly telegram drama. Lynn, what do you do to de-stress from work?
I come to Greg's house. Well, before I busted my knee, I was a runner. And that's what I did. Now I walk the dogs.
Yeah, and your dogs are adorable. Would you like mine?
No.
Okay.
So
Yours is too big.
let's your dog is big, Alex.
Yeah, and she's a lovable oaf.
Let me piggyback on that for those of you who don't know. Lynn, again, is back with us as our guest. Lynn was our first guest that we had in our podcast, which is the
first guinea pig.
Which is the perfect person, I think, to end the podcast tonight with our season 1 finale. So we're going to go through a lot of questions. But again, I can't thank you enough for being on those original episodes. They were super popular. Again, I think going from a medic to a nurse is such an interesting transition, and I think it's something that a lot of people think about. And there's nobody better to give that perspective than you, and we're super happy that you were back on the show. Do you want to come back for season 2?
Heck yeah.
All right, awesome. Yeah, so
it was fun.
So I got some tough questions for you. Are you ready?
Oh God. Okay.
All right. So has the career of medicine, and I asked this to our doctors who are in the room also. Yeah. Has the career of medicine ever caused strain on your personal life or personal relationships?
Yeah, because they don't get it.
So what is does your wife work in medicine?
Well, kind of.
Yeah.
She's in the drug and alcohol world, so she does understand it. She doesn't understand like some of the more traumatic calls or the more brutal calls that we have to go through.
Sure.
But she does understand. My previous relationships did not understand that at all. Probably why I didn't end up marrying them.
And happy a couple days belated anniversary.
Oh, thank you.
Oh, it is your anniversary.
Thank you.
Congratulations. Yeah.
1 year.
You guys
awesome.
made it.
We made 1 year.
With infinity to go.
I will hit 29 on Saturday.
Heck
29.
Yeah. Congrats.
Congratulations.
What's the
That's
secret?
awesome.
Tell us all the secret.
Tell us all the secret.
Is it booze?
No. It's not. It's the secret is when you're really truly frustrated, you just sort of take a deep breath and step back and say,
yeah.
What have I done that probably frustrated the crap out of my wife? And realize that
you just made best friends with my wife.
Yeah. No, you just you step back and you take and you go, yeah, I probably am not nearly as good as I think I am.
And Mark's wife Kay is an absolute gem, and that probably has something to do with it as well. As is.
Yeah. How does your husband? I mean, do you tell your husband about?
He
some
can't.
Of the crappy...
No,
he
can't even handle like talking about anything regarding medicine. Like I preface like, oh, they put an IV in. Nope, we're done. Done. Can't talk about it. Can't talk about it anymore. But he's really understanding, which just I can vent about the frustration and stuff. So he understands that, and he works as kind of like a consultant. So he has to deal with people a lot. So he understands the people interaction portion.
Sure. My wife was in medicine for many years before she retired, so she understands that. She understands that she hasn't worked in medicine for 25 years, but she does understand that part.
Yeah.
Yeah.
And it's not so much the gruesome parts of it. It's just like the venting about it and the I don't know. Yeah. The frustrating part about it. God, I've been sitting out there way too long. You should have had me in here like.
No way! You are the perfect person to end the show with. So let me ask you, Lynn, and I'm going to ask this to you, and then also adjunct to Dr. C and Dr. Haley.
Yeah.
Do physicians? Did you pass your nursing?
No, I'm taking it at the end of the month.
We're going to say that you're passed because you are a nurse at this point. You are our nurse on our show.
Okay.
So because I know you work in a capacity which is very much similar to nursing. It kind of seems similar. Do physicians look at you differently as a nurse as opposed to being a paramedic when you might pick up somebody from the hospital or whatever it might be? Is your relationship with doctors differently that you're a nurse?
A little bit.
How so?
And I hate to say that.
No,
a little
please.
bit.
Yeah. These are tough questions, so.
So when I roll into an ER, minus Lakeview, because Lakeview's super good about this. Yeah. But when I roll into like a bigger hospital, I feel like my judgment and my diagnosis per se is not as seriously taken as when I have my nursing degree behind me.
Sure.
Which is super frustrating because I feel like my nursing schooling and my medic schooling have been kind of handed, like, you know, it's a toss-up. I think that some aspects of medic schooling was harder, and I think that some aspects of nursing was harder. But I do not think that medics are respected enough, I guess.
Yeah, for sure.
And that it's
Absolutely
super frustrating.
Yeah. So I and I'm going to give it to both the docs here real quick. I don't mean to cut you off. So I was teaching ACLS, for instance, today, and one of the biggest parts of my instruction today was that I want paramedics to earn the respect in the medical community, and I think there is a lot of room for improvement in that regard.
Yeah.
We're a young profession. It's only been 30, 40 years as opposed to doctors and nurses who have been around for centuries, for Christ's sakes.
Right.
So it takes good clinicians and good people in those positions to educate not only the medical community but the layperson about what paramedics can do. And that is not getting on a blowhorn and standing and shouting at the top of your lungs saying, I can do this, I can innovate. Nobody cares that you can innovate. Nobody cares that you have these skills. What they care about is, are you a clinician? Can you take care of my family member when they need it? And are you good at medicine? And that is the biggest thing that I think paramedics need to understand going forward if we want to continue to legitimize our career, to be on equal footing as the other people that are with us.
I don't think that paramedics get enough credit, though. Like, we're before the curtain rises. You know what I mean? We're out there in the trenches, whatever. Yeah. So you get to the hospital, and I feel like that's really when the curtains rise, and like that's when the lights are shown down. And I mean, yes, the nurses and the physicians are taking over, and they do an amazing job. They know a lot of things that medics don't know, or they know more about.
Been taught differently.
Right.
Yeah, for sure.
But I think that a lot of focus is on the hospital setting.
Yeah.
Compared to the pre-hospital.
So, Dr. Haley, we'll go to you and then to Mark next. So, do you look at your nurses differently than your paramedics?
I don't.
All right,
because she's awesome, though. That's because she's awesome.
You are pretty awesome, yeah.
And, you know, I think that for me, even like myself integrated, I trained in the era of more this is a team approach. So, like, the doctor plays a role. The nurse plays a role, the medic, the pre-hospital personnel play a role, all in the continuum of the patient care. And I think that's the way I see things personally. Like, not one is necessarily better than the other. Some have different knowledge places and different areas where they're the experts. Because I would argue that, you know, medics, you are the experts in the pre-hospital setting.
Sure.
It's not the nurse who works in the you know, the floor.
And I think a lot of nurses would tell you that too.
Yeah,
I mean,
I think that there are definitely roles.
Yeah. How about you, Dr. C?
So I want to bring a few things basically to the fore. When does the care of the patient start? Care of the patient starts when that patient or somebody else picks up the phone. That's when care starts. Okay.
Yeah.
That's when care starts. The consideration is I have multiple paramedics who have gone on to become nurses. To them, they consider that an advancement in their career. But when you talk to them, the lessons they learned as a medic has influenced them far more than what they learned to do as nurses. Okay, absolutely, 100%. And the other consideration is when one of the things we've tried to institute we put in our institution, I think a number have, is when a critical patient is brought into our stabilization room. One of the things that happens is everybody stops and listens to the medic. Because they have a very important message and story they need to communicate.
The trauma timeout.
Yes.
So,
but the critical patient timeout.
Yeah. That's what we always called it, was the trauma timeout, right? At your hospital, there's the big sign over my head, so as I'm giving a report, I can read the sign, be like, that's what they want to hear. That's all you have to say. Just read that.
Go through this.
Yes.
I walked into a different level 1 trauma center as a new paramedic, and the resident walked up to me and leaned in. He goes, "You have 60 seconds and then I'm not listening." And I went, this is the patient. They're very sick and I did these things. Okay, thank you. It was the worst thing. And that timeout has changed so much in that dynamic. Now, Dr. Contorado, you work at a service that, because of the nature of flight, you have medics and RNs.
Yeah.
And I think that also, as do you guys in some capacities, I think that changes it a little bit as well, right?
Yes.
So we look at our medic RN teams in our air service as a equally accountable and culpable pair, right? They are the pair that's taking care of the patient. And when you talk to the medics or talk to the nurses, what they talk about is, they're way better with the RN's a little bit better with the pump and with the drips, so I kind of lean on them. I'm better with the airway, so I kind of do that. But at the end of the day, when you talk to them about a call, they were equally together, and I think that's an advantage. And I do think that there are differences between the critical access hospital and the SNF and the tertiary care facility in the way that we look at things.
So I want to share an interesting story. About 2 years ago, I was called out to a scene in near Northfield where they've called for a physician because they thought I was going to have to amputate a leg to get a guy out.
This is the best story ever.
Get the guy out of the rig, out of this truck, huge truck. Just as I get there, I hear this huge cheer, and the firefighters have pulled this guy out. And, his leg's kind of mangled, but not too, not too badly.
But begrudgingly, folds his saw back.
Yeah,
puts it back in the...
So, but I'm in my EMS uniform, and we take the patient to a trauma center. We bring the patient in.
And you rode with, right?
And I rode with, and I watched exactly how the medics were treated by the staff there. And as the resident, as the resident was going in to do their assessment and do everything, and I said, "Oh, by the way, this, and this," and they looked at me and they said, "Yeah, I understand. You guys can go now." And then the resident looked at me, recognized that I had actually been his attending, and saw the physician rocker, and you could just see the face kind of fall.
Yeah.
And they were like, crap. It is so deep right now.
How many free cups of coffee did you get out of that?
I got none.
I was going to say, what did he offer you from that
I
point
got
on?
none.
Do you want my house?
My house. But I think it's, one of the things I think is absolutely critical in emergency medicine is that the emergency medicine in training, emergency medicine residents don't ride enough with EMS crews. They don't. They do it begrudgingly.
Some really enjoy it.
Some really enjoy it. I mean, to me, it completely changed my career. I found something I had never seen before, and I had never been involved in EMS before. And I was like, this is so neat. I want to do this the rest of my life. And
the crappy thing about it is though, when we have a resident, it's like crickets.
Sure.
Nothing happens.
Yeah.
They're always
don't
a white
see critical
cloud.
calls. Yeah. So I feel like when we have pharmacy students or MD students or whatever, they get this idea that's like, oh, they don't do anything.
Right.
Because they're this giant white cloud.
Yeah.
Right.
Go to for a hangnail.
It's not really like this, I promise. They're like,
But can you But can you pass the remote?
I can tell you at the medical school I went to, the emergency department was where the internal medicine residents went to go sleep. That's what they did.
Yeah.
Okay. It was just like, we draw labs. And it was. Granted, that was a time when emergency medicine was truly still in its infancy.
Yeah.
And to me, that is. I'm so happy that EMS is now considered a subspecialty and has its own distinct body of knowledge, because it truly does. And Dr. Carrie, I don't know how your EM partners probably look at you a little differently than they look at the rest of your staff. They do that to me. I've gotten used to it. I showed up in uniform one day for a staff meeting, and one of my partners said, "Oh, you're in your mall cop uniform."
Now, in their defense,
all I had to do was look at that person, and they were like, you could see them start shrinking in their chair.
But in their defense,
there was no defense.
No, Alex. I agree with Mark.
Terrible.
Come on. No.
There was no defense.
No,
they just
there's
started
no defense.
shrinking in their chair, and
As
at
they
the end of our meeting, they're like, "I'm so sorry."
and
my response was, "You damn well better be."
And I take, Greg knows and Lynn knows about my shirt dresses. I take a huge amount of pride in my uniforms. I'm just literally giving you a
they
little
hang
bit
down
of
to your knees.
You know what though? They never come untucked. They never come untucked.
Uniform dresses is what Alex
More
wears.
nightgowns. Yeah.
So
they're real cute.
So I'm going to give it to Alex here real quick after I make just one quick statement, and then we're going to kind of go through our outro. I kind of have a little thing that I wanted to say, again, before I give it to Alex. But Dr. Haley and Dr. C, thank you for being back. I got to tell you that you...
Can I come back for season 2?
Absolutely.
All right, thank
you.
you.
are both welcome back for season 2. Along with Bjorn, who's not here tonight. We're all mad at Bjorn. Anyways.
Where is he?
I don't know. We don't know. But what I wanted to say was that you coming on this show and providing this kind of a dialogue to the masses that are going to listen to this and the people that are watching and everything else, it shows us that physicians are human too. And I think there's such a holdup by people that, especially the layperson, they think that, physicians and docs, and very much deserving so, are the epitome of like every single answer. And I love how you tell us about, your fears and your scare and how it's scary for you and how you progress. And I think that makes such a great dialogue for people to see. So from the bottom of my heart, I really appreciate that from both of you and Bjorn, who was on before, to do that for us. So, you were looking at me.
In reference to Bjorn, I was never a wacko.
So, Alex, I want to give it to you for a quick outro. Then I got a couple things to say.
We have the helmet.
All right, this is for you. Right here.
It only took them the whole show to actually put it on.
It doesn't fit.
Well, of course it doesn't fit. You have your headphones on. You have to take your headphones off.
Well, I need to hear you.
Okay.
Can you put the visor down, please?
No, I cannot. It'll cover my face. I really appreciate all of you, the both of you, to be here today. And just getting to work for both of you has been a really tremendous thing for me in my career.
They're laughing in the other room because I can hear them right now.
I don't look. There's very quickly to interrupt.
I don't want to cut it off. But
Very quickly to interrupt my outro. Alex Tremblay has 3 rules for success. 1, shake everybody's hand and look them in the eye. 2, never be the first person to do anything. And 3, do whatever it takes for a laugh. So here we are at rule number 3. This is my 10th year. I just got my National Registry "Thanks for not giving up yet" placard. And I am not the person that I was in any capacity when I started this. No. And Dr. Conrado was my physician preceptor during EMT and paramedic school. I got to follow him around and like swab throats. And if it had not have been for that, I would definitely probably still be running roller coasters at the Mall of America. And
I heard about that.
Yeah,
You did not do that.
I did. Yeah,
He did. I did. Yes, I actually know some of the people who we worked with.
The Pepsi Ripsaw, in fact. So I appreciate what you guys have done, not just for this show, not just for my career, but for the EMS services that you look after and care for, and making us world-class providers. So thank you very, very much, and thank you for being here. Dr. C, your cohort, Dr. Tangy, is going to come on and do a community paramedic show in season 2.
That'd be great.
So we'll bring you back for that. You cannot wear a Hawaiian shirt. It's better declared.
That's not Hawaiian.
It says Honolulu on it.
Oh.
You can't get much more Hawaiian than that one, Lynn.
So
it says Honolulu Fire Department.
So this show has been a wild and weird journey filled with just this fabulous pack of weirdos and then a bunch of listeners. And I wouldn't change a darn thing. So
Doctors, go ahead. Sorry.
So sorry to my dog for being in her kennel for this long today. She had to go back in for the show, but we'll take care of it.
Dr. C, give us your outro, and we'll see you in season 2.
Well, happy to be here. EMS has been the part of my emergency medicine career that has been the most satisfying, the most fascinating. It has changed me so much for the better. And, I'm half-time EMS, half-time emergency medicine. EMS is what keeps me coming back day after day.
Yeah.
End of statement.
I like it. We'll see you back in season 2.
Yes.
Dr. Haley.
This was great. Thank you for having me. I'm glad I could make it. For me, throughout all of my career choices, a lot of it had to do with the people. So I went into emergency medicine because of the people, and the same thing goes for EMS. I went into EMS because of the people. It's a great group of medics and EMTs and first responders that I get to work with and get to talk to, and I think it's just great to be part of that team and be, pushing forward for the profession itself.
Awesome. Lynn.
Oh, me.
Yeah, you get the outro.
I thought you were gonna skip over me.
Hey, you had our
cool.
intro with the show. You get an outro. So, yeah.
I just want to thank the doctors for seeing what we do and pushing and being behind us, having our back. I feel like EMS, we get shoveled to the side, but to have people like you two that are holding us up from the back like that feels good. We've got some solid people behind us, pushing us forward, whether that means EMS is going to get into, bachelor's and further education and just greater care that we can provide. People like you is what is going to push us forward. And I appreciate and thank you guys for having us and understanding what we can do on the
This
street.
is not a job. This is a career.
Yeah. Touche. You are right. This is
a career. We'll help you make it a career.
Thank you.
That's what we want you to do.
Yeah.
Because you know what? You bring years of experience and insight to this career. We can't. There's no way to replicate it.
Mm-hmm.
And what you bring to this, we want you to keep and pass on to the next generation.
We'll try. Right, Greg?
I love it. Yeah, so I got a little bit of an outro, and I appreciate all of you again. Dr. Haley, Dr. C, thank you so much for being here. We sincerely appreciate it. We want you back on as long as you're okay with it. And Lynn, of course, you have an open invitation to be on whenever you want. If my wife is listening outside right now, yes, Audrey can come in. She can sit on my lap as long as she sits very quietly as I kind of talk about a couple things while we kind of end the show here. So first and foremost, I wanted to thank our previous guests that have been on the show. So first on the list is Lynn. Lynn, we love you to death. We love the fact that you are a nurse now, and we think it's fantastic, but you're always going to be a paramedic to Alex and I and probably every single other person in that room right now.
Thank God.
Medic first, I'm sorry, for whatever reason. And then some of the other guests that I really wanted to thank, so Chad Gaither, who's not here right now, he is working. He told us that he was trying to get off of his shift so that he could be here. He was on during our, what was it, Alex? Sepsis?
Yeah, it was that one. It was early on, like it was 3 or 4.
I think it was actually the one right after Lynn, so it was about sepsis and airway management. Again, Chad, a very talented clinician in the pre-hospital setting, works as a critical care paramedic. excellent clinician and was a very, very good, yes, my wife is texting me right now, yes, Audrey can come in. She just has to be very, very quiet and come in right around Lynn, and she can come in and sit by me. So Chad, thank you for being on the show again, and you can come back anytime. Tim Wessels. Tim, I know you're sitting out there right now. I love Tim to death. I went to medic school with Tim. Tim is a firefighter paramedic, an incredible clinician. He's also very much a black cloud.
Oh,
and
yeah.
he would tell you that because Tim sees more than I think most people see in probably 10 to 15 years. And Tim has adapted incredibly well to all of those stressful circumstances. He's a phenomenal clinician. He was on our show talking about the firefighter perspective and the paramedic perspective and how that kind of differs. So, Tim, thank you for being on the show. Thank you for being here. Please have a shot and have a drink as much as you want in that next door. Here she comes.
There
This is
she
my
is.
wife. All right, come over here. Come over here.
Hi, Peanut.
You got to sit here and be really good, okay? Okay, you want to sit on my lap? Sorry. Okay. And then I also wanted to thank Jeff Price. So Jeff Price was on our show earlier in the season, and he was here just a little bit earlier talking about pediatrics and pre-hospital medicine. Jeff, thank you for being on the show. Nick Barrett and Mark Titillo. Titillo was not here.
But he's watching.
I know that you know Mark
Mr.
Titillo.
Tutilla and I have a long history, and Mr. Tutilla was the person who got me involved in tactical EMS many years ago.
So,
I have aged out of that now, and now I just run with the fire people.
So again, Mark was. You want to say hi? Oh, she want to say hi. Okay.
Yes,
but yeah,
Mr. Tutilla.
Yeah,
I miss you.
Mark was on the
still
show.
We'll see each other again.
That's right. And Mark, again, you're welcome back on season 2. And then last but not least, Bjorn Peterson.
Bjorn.
We're all mad at Bjorn right now.
Bjorn.
I hope he's watching and I hope he's listening. What the heck, Bjorn? No. We are almost done. Are you mad? Are you mad at Bjorn? Yes. We're all mad at Bjorn. But last but not least, before I say anything else, I want to thank Alex.
Oh,
I'm gonna make him tear up. I'm gonna make him tear up.
I'm gonna
right
put
here.
this visor down.
You're ready for
Yeah.
this? You ready for
Now
this?
it's time for the
This, hang on just a second. I want to point out that, true to my word, I wore this helmet, and it smells like the inside
This
of
is
a
true.
Lay's barbecue potato
Oh,
chip
okay.
bag. It's smoky and weird.
No,
Julie said she melted the shit out of that thing. So.
it looks like it too, to be
It
honest.
does. It does. It looks well used and well loved.
Okay, Greg, I'm prepared.
So, on a serious note, Alex, you are my best friend. You are the co-host of this show. I couldn't have done it without you. Again, this was a product. This was a thought in both of Alex's and my brain. I don't know, several months ago, and we just decided to put it to practical use, and it exploded into what it is now. And the popularity, we never thought that it would be that, right, Alex?
No.
We never thought that it would be what it was. But quite honestly, I couldn't sit here and just sit and talk to my guests without you. People wouldn't want to listen to just me. They want to listen to you. And conversely to that, people probably wouldn't want to listen to you and I sitting talking about Star Wars, too, for about 3 hours.
But we could.
We could, seriously. But from the bottom of my heart, I love you to death. I'm super excited for the summer content and season 2 coming forward. So with that, I'm going to sign out, and Alex, you can finish it off, and then we'll sign off.
I did not prepare a talk. Greg warned me that he prepared one, but in my head, I imagined us like reading our vows to each other, and it got really, really fast. But this has been a really amazing thing for both of us. Greg is my closest friend on the face of the planet. We talk about literally everything, and sometimes that's odd, but
Yeah, we're not going to talk about that.
yeah. So awkward.
Yeah.
So going
Little
from
turtle back.
going from a USB microphone and being like, a couple hundred people listen to this a month, that'd be cool, to this setup, which thank you, Natalie and Greg, and the contributions that we've made along the way.
Yeah.
It's amazing, and there's no better way to spend a Friday night. So thank you guys, everybody, for listening. And then, hey, Greg,
Yeah.
you want to do karate in the garage?
Absolutely. Are we now best friends?
Yup.
Okay, we're going to end it right there. So again, thank you for watching the season 1 finale. We will be back in season 2 sometime in the fall. Thanks for tuning in. We'll see you later.